or it's known as stroke. These are the outlines. We have an introduction, epidemiology, classification, etiology and risk factor of cerebrovascular accidents, the pathophysiology, the clinical picture and how to approach the patient who present with cerebrovascular accidents. So let's define what is cerebrovascular accident or a stroke. It is an abrupt onset of neurological deficits that are attributed to focal vascular causes. The neurological signs and symptoms lasts for greater than 24 hours, or there is a brain fraction is in the part of the brain there is an infraction, and it also refers to either of the cerebral infraction or either of the non-traumatic cerebral hemorrhage. And this cerebrovascular disease includes ischemic stroke and hemorrhagic stroke, and it also includes the cerebrovascular abnormalities like intracranial aneurysm or atriovenous malformation. These are also under the cerebrovascular disease. So cerebrovascular diseases are these three entities. From this point of understanding, to say stroke, it must last for 24 hours. If it is a sudden and focal neurological deficit that results from vascular origin and lasts less than 24 hours, it is known as transient ischemic attack. The threshold is 24 hours. It is arbitrarily taken in the mid-1960s. After that, some authors revise this definition, and by their definition, there may be an ischemia with neurologic deficit that lasts 24 hours to 7 days. Around 1970, they considered as transient ischemic attack may occur after 24 hours, and the concept of this 24 hours currently it is obsoleted because of sophisticated investigations are there, like MRI. The MRI shows that there is an infraction. Around 1/3 of the patients have infraction in MRI. So in transient ischemic attack, by definition, there is no infraction, but there is an ischemia. So the definition is not appropriate for this scenario. So during current days, or in 2002, the working group of this stroke group population defined transient ischemic attack as a brief episode of neurological dysfunction that's caused by a focal brain or retinal ischemia, which results signs and symptoms that lasts 1 hour without the evidence of acute infraction. In transient ischemic attack, there is no infraction. So if there is infraction, it is known as a stroke. So in transient ischemic attack, we have no infraction is no there. So this stroke, as I said, it is classified into two, mostly the ischemic stroke and hemorrhagic stroke. The ischemic stroke accounts 85%, and the hemorrhagic stroke accounts around 50%. And again, the ischemic stroke can be thrombotic, that's around 25%, and embolic, around 75% of the ischemic stroke is embolic. And the hemorrhagic one, again, it can be divided into intraparenchyma, subarachnoid hemorrhage, and pure intraventricular hemorrhage. So the scalp, and below the skull bone there are subarachnoid spaces, and below the subarachnoid spaces there is a brain. The brain can have lobes: the parietal lobe, the occipital lobe, the frontal lobe, and the temporal lobe. And there are many vasculatures which supplies different part of the brain. So each lobe has its own location and its own function. So let's start from the frontal lobe. Frontal lobe, mostly it is related to the movement, related to the intelligence, and it related to the behavior, and it related to memory. So frontal lobe is related to these functions, and the temporal bone is related to speech, behavior, memory, hearing, and visions are mostly associated with this temporal lobe. And on the occipital bone lobe, this is responsible for the vision, and the parietal bone is associated with intelligence, language, sensation, and reading. And there is also the brain part, which is cerebellum. Cerebellum is important for balance and coordination. And brainstem. Brainstem is the most area that human being can be maintain their breathing, blood pressure, heartbeat, swallowing, and consciousness levels are associated to this brainstem. So the brainstem is associated with these functions, that is breathing center, blood pressure center, heartbeat, swallowing, and consciousness are associated with this one. This is the right half of the brain, that's medial view. There is a frontal lobe, parietal lobe, and occipital lobe, and there is also a pituitary gland at the middle, and the brainstem involves the midbrain, bone, and medulla. These are the parts of the brain. These are the lateral view of the brain. The above the red is the frontal bone, the middle one is the parietal bone, and the temporal bone is the middle, and the green one is the occipital bone, occipital lobe, and there is cerebellum, and there is brainstem at the inferior side. This is a coronal view of the motor and sensory cortex. You see that there is a pre-central gyrus and post-gyrus areas. The pre-gyrus is the motor area, and the post-gyrus is the sensory area. It is the localization of the brain. It's important to localize which area is affected and which area is mostly localized. So in general, stroke is an abrupt onset of neurological disease that attributes to a focal vascular case. Clinical manifestations are variable because of the complex anatomy of the brain and its vasculature. As you see from the picture, there is a complex anatomy of the brain, and it has also complex neurovasculature. So the clinical manifestations are very vast. So stroke is usually of rapid onset and that lasts longer than 24 hours. If the patient survives to say stroke, it must be more than 24 hours, or if there is any brain infractions, regardless of whether the sign and symptoms are persist. So if there is infraction, we say that it is a stroke. In case of transit ischemic attack, or in case of this transit ischemic attack, all neurological signs and symptoms are resolved within 24 hours. There is a sign and symptom of neurological deficit, but this neurological deficit must be resolved within 24 hours. During this, there is a reduction of blood flow for several seconds that causes cerebral ischemia. If the cessation of the flow lasts for several minutes, they can cause cerebral infarctions. If it is generalized reduction in the cerebral blood flow, they can cause syncope. That's due to the arrhythmia, myocardial infarction, or shock. If the reduction persists for longer duration, there may be an infraction in the border zones between the distribution of the major cerebral arteries. There may be a formation of infractions, and if it continues and if it became severe, they can cause global ischemia and hypoxemia can be occurred. That results widespread brain injury, and the result of that brain injury can cause cognitive sequelae that's known as hypoxic ischemic encephalopathy. So if ischemia is there and if there is hypoxia, if it is widespread too along the brain, they can cause cognitive abnormality. That cognitive abnormality due to ischemia and hypoxia is known as hypoxic ischemic encephalopathy. Epidemiologically, this is the most common and devastating neurological emergency. This is the second leading cause of death worldwide. 25% of lifetime risk of stroke is for age greater than or equal to 25 years. It is the second most common disabling condition. In USA, around 795,000 people are experiencing stroke annually, and among these 77% are the primary stroke. And the etiology, when you see the etiology of the stroke, that is ischemic and thrombotic, the ischemic stroke can be caused by thrombosis. It can be due to embolic occlusion. It can be due to hypercoagulability disorder. It can be due to venous sinus thrombosis. It can be due to fibromuscular dysplasia, and it can be due to vasculitis. And the hemorrhagic shock can be due to head trauma, hypertensive hemorrhage. It can be due to transformation of the previous ischemia. It can be due to the metastasis brain tumor, and it can be due to coagulopathy, and it can be due to aneurysm. Drugs can cause this hemorrhagic stroke. So let's see ischemic stroke. This is due to a decreased blood flow of the certain part of the brain. If there is a decreased blood flow in the brain, that results ischemic stroke. If the blood flow is restored prior to a significant amount of cell death, the patient may experience only transient signs and symptoms. That is known as transient ischemic attack. And the tissue surrounding the core region of the infraction gets ischemic, but reversibly dysfunctions are called the ischemic penumbra. The ischemic penumbra is the part of the brain which is the reversible part. There is ischemia, but it can be reversed if we treat aggressively, and if we treat this if we reverse the blood flow, we can reverse this penumbra, and we can reverse the brain functions before the occurrence of the infraction. So the relationship between the duration, the degree of cerebral blood flow reduction with tissue injury is associated to the times. That means if there is a cerebral blood flow that is in ml per 100 gram per minute is from 10 to 40, it is the time that the penumbra will be occurred. Normally the cerebral blood flow is greater than 40 ml per 100 gram per minute. If it is less than 40 ml, it is penumbra. If it is less than 10, that results in fraction. So the time is our target to treat our patient. This is the time, that is the golden hour to save number lives. Our main concern during the management of the ischemic stroke. These are the risk factors of ischemic stroke. There are modifiable and non-modifiable risk factors for stroke. The non-modifiable ones are age, gender, family history, and genetics. The modifiable ones are arterial hypertension, transient ischemic attack, carotid stenosis, carotid disease, diabetic mellitus, dyslipidemia, smoking, excessive alcohol, high fibrinogen level, and high homocysteine and low folate level, and anti-cardolipin antibody are the modifiable ones. So there are modifiable and non-modifiable risk factors for ischemic stroke. So for modifiable risk factors, we can decrease the occurrence and we can prevent before the occurrence of this disease. So when we see the cause of ischemic stroke, there are common causes and uncommon causes. From common causes, as you know, the ischemic stroke can be thrombosis, can be embolic. So the thrombosis is due to small vessel, or due to large vessel, or due to dehydration. So thrombotic stroke can be secondary to dehydration, secondary to large vessel thrombosis, and secondary to lacular stroke. That means a small vessel stroke. These are the causes. When we see the embolic stroke, it can be due to artery to artery emboli, it can be due to cardioembolic, it can be due to paradoxical embolus. When we say artery to artery, it can be from the carotid bifurcation, from the aortic arch, from the aortic dissection. When we say the cardioembolic, it can be from the atrial fibrillation, it can be from the mural thrombus, or it can be from the myocardial infractions, and it can be from dilated cardiomyopathy, it can be from valvular lesions like mitral stenosis, mechanical valve, or it can be from bacterial endocarditis. When you say paradoxical embolus, it can be due to atrial septal defect or patent foramen ovale, and sometimes the atrial septal aneurysm can cause this embolic stroke. And there are also other uncommon causes of ischemic stroke. These are hypercoagulability disorders like protein C deficiency, protein S deficiency, antithrombin 2 deficiency, antiphospholipid syndrome, factor V mutation, beta thalassemia, polycythemia vera, sickle cell anemia, nephrotic syndrome, also inflammatory bowel disease, oral contraceptives, venous sinus thrombosis, and vasculitis. These vast, even systemic malignancies can cause this ischemic stroke. So the cause of stroke is very vast, but commonly it's due to large vessel thrombus or small vessel thrombus, or artery to artery, or cardioembolic. These are the common cause of the ischemic stroke. The clinical picture and the stroke types: there are intracerebral hemorrhage, there are subarachnoid hemorrhage, ischemic hemorrhage, ischemic can be thrombotic and embolic. So based on clinical presentation, how we identify these patients. If the patient is presented with gradual progression during minutes or hours, it can be due to intracranial hemorrhages. If it is abrupt onset of, if it is sudden, if there is severe headache, if focal brain dysfunction is less common than With other types, it is subarachnoid hemorrhage. Subarachnoid is the main clinical presentation for subarachnoid is severe headache. And the other one is the ischemic, which is thrombotic. In thrombotic type of stroke, there is a stuttering progression with a period of improvement. There is focal neurological deficit, and there is improvement. There is focal neurological deficit, there is improvement. This is stuttering types. That means lacunes develop over hours or at most of the days. Then large artery ischemia may evolve over a long period of times. So the ischemia from ischemic stroke, the thrombotic one is stuttering types, but the embolic one, there is a sudden onset of deficit with maximal at onset. That means clinical finding may be improved quickly, but the neurological deficit is maximum at the onset. So these are the clinical presentations to identify the intracerebral hemorrhage, subarachnoid hemorrhage, thrombotic stroke, and ischemic stroke. That means embolic ischemic strokes. So what are the risk factors? There are different risk factors for each categories. For example, in type of ischemic stroke, which is embolic, the atherosclerosis